All right. Hopefully my screen is being shared. So my name is Jacob Pellinen. I'm one of the epilepsy doctors at the University of Colorado on the adult side. And today I'm going to be talking about delayed diagnosis of epilepsy, which I think is an important topic for Epilepsy Awareness Day. And I'm going to be talking about some of the causes, the consequences, and possible solutions for this issue. And so to begin, I will briefly review some of the diagnostic criteria and treatment guidelines that we work with, and then get in more to discussing factors contributing to delayed diagnosis, some of the consequences, and some potential interventions and things we're doing to try to improve recognition of new onset focal epilepsy. So I'd like to start with a case and just to try to highlight the issue and kind of bring up some of the points. So this is a case of a 35-year-old right-handed woman with no past medical history who began experiencing recurrent episodes of altered sensation and behavior. And the first event she experienced was actually while driving, and she didn't really know what happened. It was just a segment of lost time in her day, and she received an email later from her insurance company telling her she was involved in a hit and run. It was all very confusing. She thought it was a mistake, and she looked at her car and noticed it was dented. So she didn't really know what was going on. She had a second event a week later, also while driving. I think this was happening during her morning commute, so there was kind of a temporal pattern to it, always happening at the same time of the day. And she hit another vehicle, didn't know what happened, went to an emergency room. They did an assessment of memory lapse, got a CT of her head, did blood work and a heart tracing, and everything was normal. And then sent her home, and she still wasn't given a diagnosis, and had another event a week later, but this one was more serious. She fractured her sternum. She got more head imaging in the emergency department. That was normal appearing. They ended up sending her home. And of course, she stopped driving at this point, but she still did not have a diagnosis, and didn't get one for another 2 months. And so this is kind of a common story. Not, the car accidents are obviously very unfortunate when they happen, but aren't always the case. And sometimes people go much longer without a diagnosis. And so to begin with, I just wanted to review the diagnostic criteria for epilepsy and the official definitions. So epilepsy is defined by having at least 2 unprovoked seizures more than 24 hours apart, or even just 1 unprovoked seizure with the probability of further seizures greater than 60%. And that can be determined by testing, brain imaging, or other risk factors, or if somebody has a diagnosis of an epilepsy syndrome. And this was kind of a big change that happened in 2014. And so being able to diagnose people with epilepsy just after 1 seizure was kind of a shift in our thinking. And shortly thereafter, the American Academy of Neurology and American Epilepsy Society came out with evidence-based guidelines for managing first-time unprovoked seizure. And the conclusions were essentially to inform somebody that has had a seizure that the greatest risk of recurrence is in the first 2 years. And then there's a number of things that can be found that might increase that risk, such as a history of a brain injury or abnormal EEG or brain imaging. And the guidelines also recommended that people should be counseled after they have a seizure, that starting an anti-seizure medication right away as compared to waiting until you have a second seizure is likely to reduce the recurrence risk during that time interval. And so clinicians should really recommend whether or not to initiate an anti-seizure treatment after a first seizure based on individual assessments, weighing the risks and benefits against adverse drug effects. And so, the bottom line from that was that treatment after a single seizure might be appropriate in certain cases. So this really increased the time at which you could diagnose epilepsy and start treatment, or made it sooner. But yet many people still, go long periods of time without a diagnosis. And so I'd like to talk about some of the contributing factors to the diagnostic delay, and to highlight some of the things that we might be able to do to improve that. So what makes this a challenge? There are obviously a lot of different things to consider after a first-time seizure, and sometimes we don't even know if what happened was really a seizure or if it was epilepsy, or if it represents epilepsy. And so, of course, clinicians should always be striving to make a diagnosis as early as possible, because there's a major cost of delayed diagnosis, not just for patients and their families and communities, but also the healthcare system as a whole. But that initial event can be challenging because there are a lot of things that look like a seizure that aren't necessarily an epileptic seizure. And it's been estimated that 25 to 30% of people referred to tertiary epilepsy centers for refractory epilepsy have non-epileptic seizures. And there's a whole spectrum of seizure mimics that can make the diagnosis challenging. And that can range from cardiovascular issues to movement disorders to low blood sugar and other issues. And a study from a while ago now showed that even people with, just as much as people with seizures and epilepsy experience a delay to diagnosis, people with non-epileptic seizures can also experience a significant delay to diagnosis. And in this study, it was an average of 7.2 years of symptoms until being correctly diagnosed. And then in my area of interest has primarily been looking at focal epilepsy, which is a common type of epilepsy in adults arising from a confined region of the brain. And there's growing evidence that the diagnostic delay is significant. And part of this is because convulsive seizures are the most recognized type of seizures, and much easier for patients and families and healthcare providers to recognize, but they're not always the initial manifestation of focal epilepsy. And so clinical seizure characteristics can play a significant role in time to diagnosis. And so to look back on some of the studies that have highlighted this, there was a study from Italy looking at that looked at 186 adults over a couple decades in Italy, and their aim was to identify 5-year prognostic predictors. But one of the findings that they reported, which was pretty interesting, was that there was an average diagnostic delay of 15.6 months. And then there was a study in children from the Connecticut study of epilepsy, in which 172 children were identified who developed epilepsy prior to age 3. And this was all comers, any type of epilepsies. And they found that 41% of children experienced diagnostic delays greater than a month after their second lifetime seizure. And if you remember earlier, I said that you could be diagnosed after your first lifetime seizure in certain circumstances. And those circumstances may have been the case with many of these children, but they nonetheless experienced significant delays, and the delays were less frequent when the seizures were convulsive. In other words, when children had convulsions, they were brought to medical attention much sooner. And then an Australian epilepsy group looked at this as well, and specifically looked at first seizure clinics and what the delays were from somebody's first symptoms until the time they were seen in a first seizure clinic. And so this was a study of 220 adults that presented to a first seizure clinic, and they had fairly specific inclusion and exclusion criteria, and they looked at two things essentially. They looked at the index seizure, which was the seizure that brought them to medical attention, as well as any prior events that they experienced before that. And they drew the line of diagnostic delay at anything greater than 4 weeks and looked at risk factors. And then they also compared people who had a delay between 4 weeks and 2 years, and those with an extreme delay of greater than 2 years. And so this is an interesting graph that kind of summarizes all of that, or an interesting histogram that summarizes that data and shows that there was a group of people whose index seizure was their first lifetime seizure that brought them to medical attention right away. And then there's a second group of people that tend to have this much longer time to diagnosis. So there's two distinct groups here. And looking at their breakdown of the index seizures, or that seizure that brings people to diagnosis, these tended to be seizures which were convulsive, or what they called disruptive, which weren't necessarily full-on convulsions, but significantly interrupted people's day-to-day activities. And so the summary of the first events table that they presented showed that many people who were having events prior to the first-time seizure clinic had non-convulsive seizures. And another thing I circled down here was that people also who were also having a longer time to diagnosis, or seizures before that, had a higher relative socioeconomic disadvantage. And this is the summary of the statistics for those findings. And indeed, people who had non-convulsive seizures or higher socioeconomic disadvantage had a longer time to diagnosis. And so to summarize that study, 41% of patients with new onset focal epilepsy didn't seek medical advice after their first seizure. And there was a median delay among all of the people that they looked at of 261 days, almost 9 months. And the diagnostic delay that they found was in large part due to the seizure semiology, or the clinical characteristics, though there were some other contributing factors, mainly in the study's socioeconomic disadvantage. And so to move on, there are a couple additional studies following that larger one. The same clinic looked at emergency room department presentations and found that about 40% of people had evidence of previous seizures leading up to that quote unquote first time seizure. And then a study I published with the Human Epilepsy Project co-investigators last year was looking at not just the time to diagnosis between people who have non-motor seizures and motor seizures, which are the non-motor seizures or convulsions, but also the consequences of that. And to give a little bit of background on what the Human Epilepsy Project is and where we got that data from, it is a large multi-center prospective observational study of people with newly treated focal epilepsy. And that study actually wrapped up with 5 years of follow-up over the past year. And it was designed to look at treatment responses and biomarkers and comorbidities. And it has several funders and a website. And most of the centers that were involved were in the United States, but there were also several in Australia and Austria and Finland. And we looked at, so initially we looked at all of the people who enrolled in the study, and we looked at their medical records, and we categorized all of the seizures they had. And to highlight the seizure classifications that we were interested in, the group of patients who had primarily non-motor seizures at epilepsy onset had symptoms that were outlined here. So autonomic symptoms, which is like flushing or heart rate changes, behavior arrest, cognitive symptoms, emotional symptoms, sensory symptoms. A lot of these things are feelings people have that aren't outwardly visible to observers necessarily, versus motor seizures, which can be more clearly noticed by bystanders. And so everyone who enrolled in the study filled out a seizure diary when they started. They documented all the seizure types they had, when their seizures started, and what the seizure frequencies were. All of the seizure types were reviewed by site investigators and classified. And we reviewed clinic notes as well that detailed patient histories to get a good idea of everybody's story. So among the participants, a little bit more than half had epilepsy onset characterized by initially only having non-motor seizures, and 201 had motor seizures at onset. And between these two groups, the clinical and demographic characteristics were similar. It was easy for the research group to classify seizure types as motor and non-motor. And the extent of delay was pretty significant. So among all the patients in the study, there was a median diagnostic delay of 219 days, which is similar to the finding from this Australian group in 2015. And so we showed a similar extent of delay. And then in the non-motor seizure group, the delay was 10 times longer. And the majority of people in the non-motor seizure group eventually developed motor seizures, and that's actually how they were brought to medical attention, was they would have seizures for weeks or months or sometimes years, and then they would develop a convulsive seizure, and that's how they would get diagnosed. And so, as you can imagine, that delay to diagnosis can certainly have consequences. And looking at that data from the Human Epilepsy Project, we were able to show that people with non-motor seizures experienced more seizures prior to diagnosis, which makes sense. They went for a longer period of time without a diagnosis. And a common pattern, as I mentioned earlier, was that they would experience non-motor seizures for months to years, and then eventually develop more severe motor seizures, including bilateral tonic-clonic seizures. And that was often what brought them to diagnosis. And so of the 447 total participants, if you look at the groups on the left and the right here, on the left side is the non-motor seizure group, and the right side is the motor seizure group. They had similar number of injuries prior to diagnosis, and for the most part, injuries were related to having a convulsive seizure. And so once people with non-motor seizures developed convulsive seizures, they developed injuries, but and the injury types were similar between the groups. The one major difference was that people who went a long period of time without having a diagnosis in the non-motor seizure group ended up having more motor vehicle accidents. which is a potentially preventable thing, because if we can improve the time to diagnosis, maybe we can improve, help avoid these accidents and injuries. And then beyond the Human Epilepsy Project, there's certainly other consequences of diagnostic delay. Just by going without a diagnosis for a period of time, people can have multiple or recurrent emergency room visits, or recurrent, potentially avoidable hospitalizations, repeat or unnecessary diagnostic testing in some cases. And sometimes people get referred to multiple different specialists before they end up in the right clinic, or could be started on medications that they didn't need. And so a while ago now, it was there was a pharmacoeconomics analysis of this, and they found that the cost of that new onset epilepsy is 5 times as much as taking care of people with an established diagnosis. And that could be in large part due to the upfront testing that needs to be done. And that only gets more expensive if there's a delay, there's repeat testing, and unnecessary emergency room visits, or emergency room visits that could potentially be avoided with an earlier diagnosis. And then there are also a lot of indirect costs associated with new onset epilepsy, which unfortunately aren't as well studied as they maybe should be, but are beginning to be more studied now. And some of these are reduced productivity as a result of sick leave, or reduced capacity while at work, early retirement, informal care needs such as family support, and of course quality of life issues, which are huge. And things like anxiety and depression are only worsened with a lack of diagnosis, a delayed diagnosis, and ongoing symptoms that aren't treated. And so one thing that we're doing to address this issue is a project, a collaboration with the Australian group at Monash University. And this is being led by Emma Foster, and we plan to enroll hopefully well over 400 people with epilepsy, with new onset seizures, to fill out surveys and help us understand the spectrum of issues that people deal with, and quantify it better, so we can get more support for those issues down the road. And a big thing that I'm motivated to do in my work is to improve seizure recognition. And that's part of why I thought this might be a fitting talk for Epilepsy Awareness Day. I think we can do a lot more to help improve seizure recognition and improve the time to diagnosis in medicine. And so we touched on the clinical characteristics that are associated with diagnostic delay a little bit earlier. So the question is really where are the easiest avenues for improving seizure recognition, or where can we make the biggest difference in that? And so one of the things we looked at in the HEP study was emergency department visits, and specifically the emergency room visits that people had before they were diagnosed or treated. And we found that 62% of people went to an emergency department for their initial evaluation when they didn't have a diagnosis. And this was a study that kind of the second follow-up study to the initial one with the Human Epilepsy Project. And we looked at the clinical seizure characteristics, the effect of that on recognition and treatment in emergency departments. And so here's a flow chart of the participants and what they experienced in emergency rooms. And on the left is the people who had initial non-motor seizures, and on the right is people who had initial motor seizures. And so if we look first at the non-motor seizure group, 114 of the 246 didn't go to an emergency room at all and were managed just in outpatient clinic visits. And a little bit more than half went to an emergency room once they developed a motor seizure, like a generalized or a bilateral tonic-clonic convulsion. And that is in comparison to people who had motor seizures at the onset of epilepsy. The majority of them would go to the emergency department after their first lifetime seizure. So the interesting groups that I wanted to compare were these two and how they were treated in emergency rooms. I'm just sorry, I'm looking at the chat right now, and I'll answer questions when I wrap up here. So the two groups that I looked at to compare were the non-motor seizure patients with non-motor seizures who went to the emergency room with a first lifetime motor seizure, and then people who had just a first seizure of life that was a motor seizure. So both these groups were coming in with the first lifetime motor seizure. The main difference was the group on the left had a history of non-motor seizures leading up to that. And so the group on the left could be diagnosed with epilepsy at that time. So the emergency rooms actually did a fairly good job at recognizing seizures. I would say, 85% and 87% in each group at recognizing that what brought a patient in was a seizure. But in the group of people who came in with a seizure and had a history of preceding non-motor seizures, only 21% of them were recognized as having those seizures leading up to that. And so the flow chart, so this shows that on the left, these are people with non-motor seizures who came in with a motor seizure. On the right is the first lifetime motor seizure. And the proportion of people started on anti-seizure medications was about the same between those two groups, even though the people on the left could have been diagnosed with epilepsy and started on a treatment at that time. So that number could have, in an ideal world, been 100%. And then we also looked at, what medication did the emergency room start? Were they admitted, referred to a neurologist, or discharged? And these were pretty similar between the groups. People were, in general, often started on Keppra or levetiracetam in emergency rooms. And similar numbers of people between the two groups were admitted or referred to a neurologist or discharged from the emergency room. And then the Australian group looked at a similar question from kind of a different angle. They looked at what diagnostic codes were given to people at the time of discharge to kind of figure out the same question. And so they looked at people who had a new onset seizure versus people who were coming into the emergency room with recurrent seizures that had been undiagnosed, and compared the two groups. And one thing they didn't do in this study was exclude provoked seizures, which muddies the water a little bit. But they still had good data in the end. A lot of the new onset seizure group had more of the provoked seizures, which I circled here. But the bottom line was that in the recurrent untreated seizure group, the majority, all but one of those patients, actually could have been diagnosed with epilepsy at that time. And even 40% 4% of the new onset seizure groups were able to be diagnosed with epilepsy based on the diagnostic criteria. So the bottom line from their study was that people with recurrent undiagnosed seizures, almost all of them met epilepsy diagnostic criteria. And most people were able to get a neurology consult in emergency rooms. They did report that only 9% were started on medication, but later in the paper, they mentioned that the majority of people were admitted to hospital. So presumably the number of people started on a medication once they were admitted and diagnosed was much higher than that, but it just wasn't reported in the paper. And so the study does bring up several questions in my mind. How likely is it that a careful history is being taken for prior subtle symptoms during an emergency? And how likely is it for somebody to report prior subtle symptoms under those circumstances if they didn't think they were a big deal before and nobody brings it up when they're being evaluated? And then how reliable is our medical record coding system? And the bottom line here, I think, is still seizure recognition being a major issue. So to answer the question from the chat, since it had to do with the emergency room, I was in the ER a couple of times and they couldn't figure it out. Does HEP have an average number of years? Yeah, so it is a common story, unfortunately, for people to be going into emergency rooms and not getting a diagnosis, not having things figured out. In the HEP study, there was a wide range of the number of years it took for people to get a diagnosis. But like I mentioned, it was about 220 days on average. That included both motor and non-motor seizures, but the people who had non-motor seizures especially had a very lengthy time to diagnosis in comparison. Let's see. Back to where I was. All right. So how can we improve seizure recognition? There's, of course, educational initiatives for the public, healthcare trainees as well, and healthcare professionals. And I think stroke neurology has done an amazing job in this area and has set a good example for us. I think that ideally we can do the same thing in the epilepsy world and bring more recognition among the public, and also improve training, medical training, and for healthcare trainees and healthcare professionals as well. And even more practically speaking, we can do things to help improve diagnosis and hopefully help those healthcare providers in emergency rooms and primary care clinics who are having a hard time figuring things out, and design a clinical tool to help them in recognizing non-motor seizures, particularly at that point when people are coming in with a convulsion. And, I don't want people to forget to ask people about prior symptoms that they've had leading up to that, because that can be so important for diagnosis at that time. All right, so to conclude these studies that I was sharing today, there is growing evidence of diagnostic delay in focal epilepsy and epilepsy in general. And prompt diagnosis is after seizure onset is important, obviously, for preventing potentially avoidable harm, and also reducing associated costs of delay. From recent studies, it's clear that people with non-motor seizures have significantly longer times to diagnosis than people with motor seizures at epilepsy onset. And although most injuries in our studies resulted from motor seizures and convulsions, most of the pre-diagnostic motor vehicle accidents actually occurred in people with undiagnosed non-motor seizures. And in addition to direct costs, there are, of course, indirect costs associated with diagnostic delay. And a lot of those things are still being investigated, and we'll hopefully figure out ways of improving those as well. And there's an under-recognition of non-motor seizures in EDs right now. And the lack of recognition leads to underdiagnosis and undertreatment of epilepsy. And the underdiagnosis in emergency departments likely contributes to the overall diagnostic delay. So findings from a lot of these recent studies are pointing in the direction of supporting projects and interventions that are aimed at improving recognition and treatment, particularly in ED settings, but this probably also will translate well to primary care settings and the other places that people go for evaluation of symptoms when they first seek care. And so there's a lot of people to thank for all the studies that were done, but I worked with colleagues at NYU who've helped a lot. Jackie French is one of my mentors and inspirations. I've had help from Erica Tafuro, Annie Yang, and Kelly Knupp at Children's Hospital is also a mentor and an inspiration. And I collaborate a lot with Emma Foster at Monash University in Australia. And thanks, of course, to everyone involved in the Human Epilepsy Project and all of the participants for making projects like that possible. Without participants, we would not be able to answer these questions and fight for improving every day. And I'm happy to answer any questions that anybody has. Feel free to send more questions in the chat. I think we have a little bit of time before the next talk.
I was just wondering because it took 12 years to figure out my epilepsy. And so that's why one of my friends texted from the Epilepsy Foundation in Greater Los Angeles, texted me the links. So I was just wondering because I just had the RNS procedure. So because it took when I was in 6th grade, a kid tased me and it wouldn't go away, and I was in the hospital. I couldn't hear, I couldn't speak. My eyes, my mom said it looked like a stroke, my entire left side was drooping, and they just made me sit there for 8 hours. And by the time they took me in, it was too late and it had finally gone away. But my mom was we were literally sitting there for 8 hours.
Yeah.
And I couldn't talk, I couldn't hear, I couldn't do anything. That's why I was wondering, because whenever I tell my story, everyone's like, how could they not figure it out?
Yeah, it's unfortunately a common thread, theme that people have to go through, years of experiences and trauma before somebody finally recognizes appropriately that they've been having seizures, or somebody can make the diagnosis, but it is unfortunately a common thing. And it's clear that we need to try to help our colleagues in the ED with, in the emergency rooms with recognizing seizures. And there's all different levels of improvement that we need to make, not just public education, but, among our medical trainees and the people who will be working in emergency rooms and the people who are currently working in emergency rooms and elsewhere. And I think it's possible to do that. And I think it's something that we certainly need to do because of all the reasons that you mentioned.
Yeah, like I'm interested, is the Human Epilepsy Project still existing? Because I'm more than happy to offer time and help.
Appreciate that. It's actually the Human Epilepsy Project wrapped up this year, and so it's officially done. But there are, other studies ongoing at our university. I'm working on that study with the Australian group about quality of life stuff, and I'm, recruiting patients for a study to help create a clinical tool that can be used in emergency rooms to help with this right now. And so there's always areas for involvement, I think.
Yeah, I'm very active in the Greater Los Angeles Epilepsy Foundation and San Francisco.
Great.
So, because I just want this word to be spread that, like, if you see someone that can't hear or speak, something's wrong with them. Don't just tell them they're creating negative attention. That's what so many doctors did to me as a kid. I'm
Wow.
like, that's why I was like looking into this um interaction, because I saw that it was like all about like space in between, like the waiting game of like, okay, what's going on?
Yep.
I mean, I was harassed, bullied all the time because I had speech delay and all of that stuff. Like,
Mm.
I was really advanced in elementary school until the epilepsy started.
Yeah.
Like, professors would down me and say, I don't want you in my class. I don't want to be liable. People won't hire me because they're like, I don't want to be responsible for workers' comp. Like, the positivity and this needs to overcome the stigma. That's
Yeah.
like right
So
now what I'm trying to focus on. And I'm assuming that's what you guys are focusing on too, is getting rid of the stigma and more awareness that non-motor seizures are not harmful, and neither is the convulsions. You just have to be aware and not scared of it.
right. Yeah. It's just we need to educate people. We need to educate, spread the word, and improve recognition overall. Uh, not just in the healthcare, but around, in the public too.
Yeah, thank you so much for your time and dedication to this, because it means a lot to people like me who have been bullied and harassed 13 years of their life.
Yeah. Well, it's my pleasure to speak today and to get to know you. And, I will obviously be continuing to work on this, and feel free to reach out, if, with anything, any other questions or anything like that.
Thank you.
All right. Okay, if that is all, can take a break. Okay, I have a question. When you think about campaigns targeting the public, okay. Yeah, teachers are important, and they are uniquely positioned to notice subtle signs and symptoms. Yeah, I 100% agree. In terms of public education, teachers will be tantamount